Welcome, everybody, and thank you for joining us this evening um, for our series of talks launched in September in recognition of Rheumatic Disease Awareness Month. These talks are presented by the Inflammatory Arthritis Center and the Integrative Rheumatology and Orthopedic Center at Hospital for Special Surgery in collaboration with the Department of Social Work Programs, Inflammatory Support and Education, Inflammatory Arthritis Support and Education programs. I'm Adina Batterman. I'm the senior manager of those programs, and it is my privilege to welcome you to the third and final talk of this series. This evening's talk is titled, Are You Thinking What I'm Thinking? Patient and Provider Thoughts on RA Treatment and Decision Making. Our format's a bit different for this presentation. We're going to have a patient advocate and a rheumatologist in discussion together to share information about and hopefully demystify treatment decisions in rheumatoid arthritis. After the presentation, there'll be opportunity for questions, and we will share links to learn more about our support and education programs and also our research centers. And now it is my honor to introduce our discussants this evening. Dr. Jenna Braverman is a rheumatologist at Hospital for Special Surgery. She sees patients with a broad range of rheumatologic conditions, including rheumatoid arthritis, psoriatic arthritis, systemic lupus, erythematosus, connective tissue diseases, and sarcoidosis. She has particular clinical and research interests in cardiopulmonary manifestations of systemic rheumatic and inflammatory diseases. And in addition to her patient care and research roles, Dr. Braverman serves as the Associate Program Director of the Rheumatology Fellowship Program at Hospital for Special Surgery and is passionate about supporting the development of medical trainees. And our interviewer, Eileen Davidson, is a rheumatoid arthritis patient from Vancouver, British Columbia, Canada. Online, she's known as Chronic Eileen, where she creates content about living with rheumatoid arthritis and her participation as a patient advocate and patient partner in research. We welcome both of you, and I'm going to exit for now. I'll see you in a little bit and looking forward to this conversation. Thank you.
Thank you. I'm excited to be here. My name is Eileen Davidson, and I was diagnosed with rheumatoid arthritis in 2025 when I was a 29-year-old single mom. So the disease hit me pretty hard, and starting treatment for rheumatoid arthritis really felt overwhelming. So did understanding the disease. But between that fear, confusion, and the flood of misinformation online, I remember feeling stunned to learn that arthritis isn't just one disease, but a family over 100 conditions, and that rheumatoid arthritis is an autoimmune disease. Even though arthritis ran deep in my family, it took being diagnosed with it to really truly understand it myself. My grandmother had knee replacements, and my aunt lived with RA long before my diagnosis. Seeing them navigate arthritis taught me how far treatment has gone since then, and the difference between their experiences and mine just shows how much progress medicine had come in the last few decades. So I'm excited to be here today for you to talk with Dr. Braverman on a topic that I know well as a person living with rheumatoid arthritis. First, though, before we dive in medications, I want to talk about what is actually happening inside of us, inside our bodies as somebody living with rheumatoid arthritis, and why we might need medications to combat this disease. Dr. Braverman, can you tell us what is rheumatoid arthritis and why exactly does it need treatment?
Sure. So, hi, everyone. Thank you so much for the introduction, Adina and Eileen. I'm really excited to be having this conversation with you this evening. Yeah, in terms of a little background on rheumatoid arthritis, and I can't see everyone in the audience, and I think we probably have a variety of backgrounds, but just so we're really on the same page, I think everyone probably has some familiarity with rheumatoid arthritis. But rheumatoid arthritis is a systemic rheumatologic disease. It's an autoimmune disease. Systemic meaning it affects multiple parts of the body. And so we always think about the joints, and we're going to spend a lot of time talking about the joints and how are we treating the inflammation in the joints. But it does affect multiple parts of the body, including the eyes, the lungs, the blood vessels, the skin. So it really is a multi-system condition that requires a very holistic approach to evaluation and to management. So Eileen, you asked about why do we need treatment? And I guess one other thing I'll just mention about rheumatoid arthritis, and again, this may be something for those of you in the audience, if any of you do have rheumatoid arthritis yourselves, you may have had conversations with your rheumatologist about this. But the thinking is, we don't know exactly why somebody develops rheumatoid arthritis. The thinking and really the paradigm for so many of our rheumatologic diseases is that someone has some underlying predisposition that's probably genetic, and there may be an environmental trigger. And there has been a lot of research on different triggers in rheumatoid arthritis. There's not one thing, but there have been certain very well documented environmental triggers such as smoking or gum disease. And we'll talk a little bit more potentially about that later in our talk about how that can be very important to thinking about the management of rheumatoid arthritis. So Eileen, now circling back to why do we treat rheumatoid arthritis? So I think I probably don't need to necessarily tell those of you in the audience who have rheumatoid arthritis why you might want treatment. I think first and foremost, we want to reverse inflammation and in doing so, improve function and quality of life. So pain, swelling, stiffness, again, functional issues that patients have. Our goal first and foremost is to reverse that and make those symptoms better. Also, in doing so, our goal down the line is to prevent irreversible joint damage or damage to other organs that that can arise as a result of longstanding active inflammation. And in doing so, we hope to prevent disability. And so we have lots of treatments now for rheumatoid arthritis. We're lucky to be in 2025 now, where really, this is not a one size fits all. We have one medication. We're very fortunate to have a lot of different options. And so, we'll probably talk more about that in terms of how we think about choosing the best medication for someone.
So many great points that you brought up. And, I've been diagnosed for over 10 years now. And I love having discussions with rheumatologists because every time I do, I learn something new. So thank you. Even though I've been diagnosed for a while, there was a few golden nuggets in there that really resonated with me. And I appreciate that. Now we're going to talk about some of the questions about when somebody is first diagnosed with rheumatoid arthritis. And it can be very overwhelming. And one of the scariest conversations that somebody can have with a rheumatologist when newly diagnosed is about starting medication. I can remember I had many different concerns when I had to start medication, especially because I was being told that now I need medication for the rest of my life. So, what are some of the most common concerns patients share when they are first told they need to start continuous medication?
Yeah, so I think that's a great question. And I'll give my answer as someone who has had these conversations with multiple people. And then I think I'd love to hear some of your thoughts as well, as someone who has rheumatoid arthritis and has connections within that community as well, to get your thoughts, because I think this is a nice two-way exchange. So we learn from each other through the course of this conversation. So I think you mentioned a sense of feeling overwhelmed about the diagnosis itself. So I do think that is something that many people, I think they may have had symptoms for a long time, and it can be a relief to have a framework for understanding what they've known and been experiencing for a long time. But it may be a newer set of symptoms, and that, all of it can be overwhelming. So I think that processing a diagnosis can be kind of a shock to many people, but it can be a relief to some others. Many people, you mentioned, the continuous medications. So I think the holy grail of rheumatoid arthritis is, how do we prevent disease from actually taking hold, and how can we cure? disease, but I don't think we're there right now. And so I, as a rheumatologist, think of rheumatoid arthritis as a chronic disease. And so I think that patients definitely have a lot of well thought out questions about what does it mean to have a chronic disease in terms of, will I need to be taking medications for the rest of my life? What are the risks of those medications? I think questions about rheumatoid arthritis itself, what will this mean for my health? So I think that there are so many questions that patients have. And I really, really do think that at the beginning of a diagnosis is so important for trust building as a physician. That I think that giving patients the space to do their research, ask their questions, for me to share information and allow that to be digested. It can be a lot for someone to process a diagnosis and then all of this information about treatment. And so I think that that's also something that I'm mindful of as a rheumatologist. Part of why I went into rheumatology is because I love and I cherish those longitudinal relationships with patients. So this isn't, you get a diagnosis, you walk out with a prescription for a medication, and that's it. And, so I think, this is that trust building is really important. And it's a relationship that will evolve over the course of months, years, decades. And so I think giving patients time to process and have space to ask their questions is really important. But Eileen, I'd love to hear, again, not to put you on the spot about anything in your own personal experience, but if there's anything that you wanted to share about those early, the early sort of aspects of receiving a diagnosis.
Absolutely. Thank you for uh, having me to share the experiences too. But I wanted to reflect, my rheumatologist went into rheumatology for the exact same reason that you did. And I think that really shows a sign of a passionate rheumatologist. And you covered a lot of the concerns that I had when starting medications because they're fairly common. And I'm sure those in the audience can probably relate to what I would consider my main concerns when I was starting medications. First and foremost was remembering to have to take medications every day. I have never really been good at that, so I've really had to work on my medication adherence. And it was kind of hard for me to kind of process that I would have to do this every day. Remembering when, fitting it with my daily schedule, remembering to take it with food, remembering to take it before bed, especially when I'm really tired. Living with rheumatoid arthritis, I really struggle with fatigue, and then cognitive dysfunction. So there's just, remembering to take my medications was a concern of mine. And then, just trying to shift through all the misinformation online, the natural is better approach that some people would kind of medication shame me before, when I was saying that I need to treat my autoimmune disease with medications. There'd be a lot of people who would tell me, oh, the medications are just going to make you sicker, things like that. So just really struggling with who should I listen to at first? And like, why should I listen to them? I was newly diagnosed. I had no experience having any medical issues aside from having a child, which was a temporary thing, child pregnancy and childbirth. It's temporary. That ended. But my having this rheumatoid arthritis disease it's not going to end for me. So I really wanted to make sure that I found, what information I needed to listen to and also time to process that information. Of course, I was, worried about harmful side effects. Uh, watching TV and seeing those commercials, and they have to listen all those side effects, and it's terrifying to listen to those. But I also had to learn that those side effects might necessarily not happen to me, and I don't need to keep taking those medications if I do have those side effects. And, wondering, are they actually going to work for me? How long is it going to be until I actually find the medication that works for me? Because there's kind of a process where we have to go through medications based on kind of what's cheaper, what's more common to use. And I have what's considered refractory rheumatoid arthritis. So I've had to cycle through lots of medications. So I would say those are my main concerns when I was first diagnosed. And I have a lot of those same concerns now. And yeah, so you did kind of already touch base on what are the treatment goals of rheumatoid arthritis, but can you walk us through what treatments are for rheumatoid arthritis. I kind of touched base on there's some guidelines that you need to approach when treating rheumatoid arthritis. And there's many different medications now than when I said my aunt was diagnosed. She was treated back when the days where gold was popular to treat rheumatoid arthritis. Now there's so many more options. Can you walk us through some of those?
Yeah, absolutely. So I think there really has been a revolution in terms of how we approach the treatment of rheumatoid arthritis, or the available options, as you said. So circling back to that, your initial question, why do we treat rheumatoid arthritis? So I think front and center, particularly for rheumatologists, is using medications that are going to alter what we would say as the natural history of rheumatoid arthritis. And the natural history meaning if you didn't do anything, what would happen? How would the disease typically progress? And our goal is to interrupt that. And so we want to interrupt the inflammation and then potentially irreversible damage by using medications. And so that is really the cornerstone of rheumatoid arthritis treatment. And we use medications called DMARDs, disease modifying anti-rheumatic drugs. So a little bit of a mouthful, but I'll refer to it as DMARDs, that have the ability to, again, alleviate many of the symptoms, but also prevent the damage. And when I say damage, and I know, Eileen, we were talking about there are what I would say extra articular or symptoms outside of the joints, but really we're talking about damage to joints that you can see on x-rays. So there are characteristic changes that you can see on x-rays from rheumatoid arthritis, but that you can also see visually. So when, I think a lot of people, when they receive a diagnosis of rheumatoid arthritis, they think of kind of classic photographs where people have deformities in their hands. And I think that can be very anxiety inducing. Fortunately, I think that now we have so many treatments that in the vast majority of times, we are able to prevent that from occurring. And so that is really, as I mentioned, our goal. And so the DMARDs are a variety of medications that have lots of evidence behind them that have led to their approval for the treatment of rheumatoid arthritis. And they have been shown to prevent that damage from taking place. So I can talk, there are many, many, many different classes. There are oral medications, there are injectable medications, there are infusion-based medications. And again, they all have the ability to interrupt the damage that rheumatoid arthritis would otherwise potentially lead to in joints. And in terms of how I approach selection of medications. So again, I think shared decision making is a really important foundational principle behind how many rheumatologists practice. We think that in general, that's sort of how we are taught now, as opposed to more paternalistic models of medicine where a doctor would, give you a prescription and send you away and that's that. So really that shared decision making model entails both patient and physician coming together, having shared goals of treatment, and really eliciting from the patient what is important to them in informing their goals of treatment and personalizing the approach. And so I think that is really critical. So patient preferences, so important. Other things that I'm thinking about in choosing a DMARD is how active someone's rheumatoid arthritis is. And that's a combination of, the symptoms that someone reports, their exams. So how many joints are tender, so are, painful on exam or swollen. Sometimes we also integrate laboratory values. So how much, is there evidence of inflammation throughout the body? And imaging also has an important role as well. So sometimes we use ultrasound or MRI that can show us inflammation in the joints. We do also rely on x-rays, but x-rays are better for showing structural changes, less so active inflammation. And then there are very important patient-specific factors that come into play. So if somebody has taken medications previously, did they have side effects? Did they have any allergic reactions that might lead you to avoid certain medications within a class? If they did take other medications, what worked before and why are they not taking that medication now? So did something work but then stop working? Did something never work? And then we think about other really important patient-specific variables that might lead you to avoid a certain medication, or we might consider a medication, what we say contraindicated. So really should not be used in someone. In certain circumstances. So that might include someone who is pregnant or is planning for a pregnancy, someone who has a history of cancer or blood clots, someone who has a family history of multiple sclerosis, someone who has significant liver disease, alcohol consumption, kidney disease. These are just some of the variables that we take into account as rheumatologists in thinking about what medication we would recommend. And then also circling back to this idea that rheumatoid arthritis is a systemic autoimmune disease, other parts of the body, in addition to the joints, may be affected, and we would want our treatments potentially to treat those other parts of the body. So the eyes, the lungs, for example, those are potentially serious organs that can be involved that we want to make sure that we're effectively covering.
Absolutely. And I really like that you mentioned the shared decision making. So it really is a conversation that you must have with your rheumatologist to find what treatment is best for you. There's not a one size fits all. So I'm happy that you talked about the shared decision making. And then I hope that some of the points that you brought up actually will help some patients develop some of the questions that they would like to talk with their rheumatologist about and their treatment considerations. Now, we're going to walk a little bit now into what patients should know when they're starting a new medication, including like how long will it take to start working, and what are some of those signs that patients should be looking for when a medication is actually starting to work. Um, Sometimes medications, they might not be perfect, but there is significant changes. Can you tell us a little bit about what that might look like?
Yeah, absolutely. I think expectation setting is really, really important. So in terms of our rheumatoid arthritis DMARDs, and I will use this opportunity to also talk about some of the other medications that may be prescribed or recommended or people may have experience with that are not considered DMARDs for RA. But in terms of the DMARDs, our general principle as rheumatologists is that we give our medications up to 12 weeks to really take their full effect. Now, the biologic medications, so these are medications that resemble proteins that are naturally made in our body. They're manufactured and engineered, but they are very, very targeted in how they work. So they have been engineered to block a specific molecule or signaling pathway very, very specifically. So those biologics, again, include injectable medications, infusion medications, and then as sort of a subset of the biologics, it's kind of related. There are oral medications. So some of you may have heard, I'll just list some to make this more concrete, but the TNF inhibitors are our first biologics that we use. We have another medication called abatacept. There are interleukin-6 inhibitors, so tocilizumab and sarilumab. They're a medication that block certain or that work that are targeted against a certain kind of white blood cell. That medication is called rituximab. And then closely related, the JAK inhibitors. So there are a lot of different biologics, but we also have older medications called conventional synthetic DMARDs, and these are oral medications. And typically, this is actually what most people will start out on as their first rheumatoid arthritis treatment. And so this includes things like methotrexate, that really is our first line medication most of the time, unless somebody has reasons that they shouldn't be taking it, which that is very common. So that may not be everyone's first, that often is not everyone's first medication, but there's methotrexate, there's leflunomide, there's hydroxychloroquine, and there's sulfasalazine. So those are the older medications. And those do work more slowly. They're more general in the way that they work, their effects in the body than the biologics, which are very targeted. So we say 12 weeks for everything. We really like to give everything a 3-month trial. But the conventional synthetics, those older medications, do work more slowly. The biologics do tend, people will often notice an effect. Sometimes people say, I took one injection of their TNF inhibitor and they noticed a difference. So again, it really varies. But there is definitely a period of weeks to months that it will take. And so sometimes people do find, especially if they're really having difficulty with their symptoms and their functional ability, that they do get benefit from medications that we don't consider to be DMARDs. So the most common one is corticosteroids. So those come in oral form, so you can take a pill. You can actually get an intramuscular injection, so some people may get a shot. And you can have an injection of a corticosteroid into a joint. So, oftentimes if someone has many joints involved, it's not realistic to, or it's not, it's not helpful to get one injection. I refer to oral steroids as our best worst friend. They work quickly. So again, it can be hard if you are, Eileen, you mentioned you have a young child, and if you're working, you cannot function. It can be very hard sometimes to hear, I'll see you in 3 months. This is going to take 12 weeks to start working. And again, we really I think our field of rheumatology has come a long way since the days of gold as a rheumatoid arthritis treatment, because there was a time in the field that really all we had was corticosteroids. And for those of you who may have taken corticosteroids, again, they work quickly, but there are lots of side effects in the short term and in the long term. And so it is built into even our guidelines now. The American College of Rheumatology has rheumatoid arthritis treatment guidelines that it is not, you should not be necessarily starting everyone at the time of diagnosis on corticosteroids. It's really a case by case basis, but I do use that if somebody is having a tremendous difficulty, suffering, their symptom burden is high, it works quickly. It doesn't alter the disease trajectory, that natural history that we talked about. So we don't consider it a medication that we would use to help protect the joints in the long term. But if someone really needs something more and can't wait the 12 weeks, or, again, also with some of the biologics, there's insurance approvals that need to happen. So even if you may make a decision about a treatment, there can be some period of time before you get started on the actual treatment. So many people do have experience with being prescribed steroids. And then, another medication that patients will often take as well are the category of NSAIDs, non-steroidal anti-inflammatory drugs. So this includes things like ibuprofen, naproxen. These medications don't tend to work as powerfully as steroids, but they can take the edge off. They are not disease modifying in rheumatoid arthritis. In other forms of arthritis, like psoriatic arthritis, we do use them sometimes as sort of our destination therapy, but not really for rheumatoid arthritis. But it's a medication that many people have experience with as well. I will note that even though these medications are over the counter, there are risks that are important to think about in terms of stomach ulcers. They can be harsh on the kidneys. They can worsen high blood pressure. They're not the best for individuals who may have heart disease. And so everything is really a risk benefit consideration and discussion.
And also, untreated RA is a risk that we have to decide on as well. So, medications are such an important part to me personally as living with the disease and having lived with it for a while. I've gone through so many different medications, and I'm so grateful that there are so many options now. I've had some that have worked for zero time. I had side effects right away, so I brought this up to my rheumatologist and we decided they weren't going to work for me. Move on. And then I've had medications where I was so close to being in remission for a long time, but unfortunately, the medication stopped working for me. So I'd like to walk through some of the reasons or signs that a medication might not be working or might need to be adjusted or changed, and why this might be common in rheumatoid arthritis treatment plans.
Yeah, absolutely. I think that's a really important question. So I think this gets to the issue of do you, as someone's rheumatologist, I am assessing at every visit, do we need, how is someone's rheumatoid arthritis doing? How are the, how is my patient doing? How active is their rheumatoid arthritis, and do we need to change their medications? So the first thing I'll say is that individuals who have rheumatoid arthritis entitled, like everyone, to have other causes of joint pain that are not rheumatoid arthritis. So it's important to be assessing for things like osteoarthritis. Um, if somebody is on, has taken many steroids, there's a condition called avascular necrosis where the bones don't get enough blood flow, and that can be very painful when that happens. If similarly, if you're concerned that someone may have osteoporosis, you want to make sure they haven't had a fracture. Other pain syndromes like fibromyalgia. So again, you need to be trying to work with your patient to parse apart what's rheumatoid arthritis, what symptoms are from rheumatoid arthritis, and do we think there might be something else at play here? And then you mentioned you've had personal experience with multiple medications, and so medications may be changed for side effects, and that's really important. And I think I don't necessarily mean to fast forward to my take-home messages, but I think that communication piece is so critical. And I tell my patients, I don't want you to be stoic. Don't suffer in silence. If you're having side effects from methotrexate, I want to know about it because there are things we can do to troubleshoot that, or we may need to change medications. So I think side effects are hugely important. Frequent infections might be another reason that someone would change their medication. And then, as you mentioned, you've had medications that never worked. So that's something that we would refer to as a primary non-response. So primary meaning this medication is not the medication for that patient, versus a secondary non-response. So the treatment worked for some period of time and then it stopped working. And I think that is important to me as someone's doctor, because I'm thinking about, for example, a class of medication. If my patient took a one TNF inhibitor and did really well for 18 months and then it stopped working, I would be more inclined to try a different medication in that same class than if they took it, it never worked. So I think there are also strategies that we have with certain medications where we can change either the dose of the medication itself or the dosing interval. So how frequently someone takes a medication or gets a treatment. So, again, that, thinking about, did they respond to it and it stopped working, or they never responded, is really helpful in trying to decide, should we keep going ahead with this medication and try to make it work or not? And one other thing, you mentioned that you personally have refractory, sort of difficult to treat rheumatoid arthritis. So thinking about, how many treatments has someone gone through before? Do we want to try to, preserve certain medications if we can? I think is another consideration.
Yes, and I think living with rheumatoid arthritis, I understand a lot of what you've said there, having to go through the different medications. But and even though I have been through so many, I can say for sure I have never really lost hope. Even though sometimes, the cycling when medications fail me. And I've learned over time to say the medications failed me. I did not fail the medications. And just keeping on to hope that, I will find another medication that brings me into remission or very close to remission, or maybe one day a cure. That would be nice. Now, because rheumatoid arthritis cannot be cured, it can, however, be put into remission. Now, remission at first was very confusing to me. I didn't really understand, well, if the disease can't be cured, but there's a treatment target you have, what does that exactly mean? Why do I need to be on medications? And if this can you walk us through exactly what remission is and how it is measured? Because it's an interesting concept, and it is. I felt like it was quite hard for me to digest at first, and I didn't really understand the signs because I do have rheumatoid arthritis, osteoarthritis, and fibromyalgia. So I do have other causes of pain. So it was very difficult for me to understand when I was so close to remission.
Hmm. Yeah, no, that's a really, I think you bring up a critical aspect of rheumatoid arthritis care, which is that as as rheumatologists, we are trying to treat to a target, and this is again baked into our guidelines within the American College of Rheumatology. And so the idea is that we want patients who have rheumatoid arthritis to be in remission, ideally, or low disease activity with and the way that we understand that, and again, you mentioned it, sort of hard to wrap your head around that, is through regular assessments that rely on both patient and physician input. And again, I think this really speaks to the importance of that patient-centered collaborative care model. So, when as a rheumatologist you're treating to target, ideally a physician is using a consistent disease activity measure that stays the same from visit to visit. So there are different ones. Some of them, you may go and read the literature when there are new, randomized clinical trials, and they're using different, the DAS28. They have different names. It doesn't really matter what you use so long as you choose one and you're consistent with your patient about it. The one that I personally use is called the CDI, the Clinical Disease Activity Index, and that takes into account the patient's global assessment of how they're doing, the physician's global assessment of how their patient's doing, as well as counts of tender joints and swollen joints. Again, some of these other measures may take into account laboratory values that look at inflammation. So it really varies. There isn't one definition of remission, but the idea is that the patient feels that they're doing well, their rheumatologist feels that they're doing well, and on their exam, there isn't evidence of very active rheumatoid arthritis.
It's so important to understand that remission also means to us as patients how we feel. Was something that my rheumatologist said when my labs were doing good, but I didn't feel good. And she said to me, you know what? Let's not focus on these labs. Let's focus on how you are feeling. And we decided to make a medication change that day. So
Yeah.
it's so important to, talk really, really express how you are feeling and how is it you're feeling impacting you throughout the day, what you're trying to do. Now, when you do reach remission or very low disease activity, do patients need to stay on medication? And if so, why?
Yeah, so that is a great question. I think going back to one of your first questions about as a rheumatologist, what are patients asking me? I think that at the time of diagnosis, a lot of people ask, "Well, I need to be on medication forever." And when someone first has a diagnosis, I think we table that question. But to sort of revisit that through the lens of the question you just asked me, so that there There's a lot of interest that patients have in being able to either taper, so de-escalate, or stop treatment for many of the reasons that you mentioned yourself in your own personal experience were challenging about taking medications. You have to remember to take them. They have side effects. There really is a burden, both psychosocially and potentially financially, with taking medications. And so, this is really a question that I approach through shared decision making with patients. There are studies that have looked at whether you can stop or reduce treatment in rheumatoid arthritis. There's an extensive series of good, well-designed trials trying to answer this question. And what the data shows is that patients who are in remission or have tightly controlled rheumatoid arthritis tend to be the ones who do the best going into a taper or medication, holiday, so to speak, but that many people do flare if they try to stop medications. And those flares are more common if you stop medication completely and versus taper things. So some people are on two medications. If you stop one medication, the risk of flaring is lower than if you stop both. But the data shows that if you restart medications, the vast majority of the people who flared when they try to taper can recapture their disease control. So, I think it is an open question. I have had patients who really are motivated to try to stop treatment or significantly de-escalate their treatment. And we approach this through shared decision making, and I do like to monitor people with ultrasounds, for example. So even if I'm not seeing inflammation on my exam, I want to be sure if they're just taking, if they were taking hydroxychloroquine and a biologic treatment and they're just on hydroxychloroquine, I want to be sure that there isn't inflammation that I'm not seeing, because we do want to prevent that damage to the joints structurally from taking hold. So I will say most of my patients don't stop treatment. It's a small section of the pie. But I think this is where sort of the art of medicine comes into play too, because you have to work with your patients and use that shared decision making. Some people say, I felt so awful before I was on treatment, I would never want to risk that. And I'm the one who said, well, maybe we can space this out now. So again, it really varies from person to person.
It really does. And, I just want to thank you so much for walking us through so much about rheumatoid arthritis medications. But living with rheumatoid arthritis myself, I do know that it does take more than just medications to really truly manage this disease. It takes some lifestyle and self-management things that I have to do on the daily, weekly, or monthly basis. Moving on beyond just medications now, can you answer what role integrative or complementary approaches, including exercise, sleep, mental health care, and other non-drug treatments, play alongside standard RA treatments?
Yeah, no, thanks, Eileen. I think just stepping back more broadly, in order to really take a person-centered approach to treating rheumatoid arthritis, you can't reduce management of the condition to just prescriptions for medications. And so I think that it's really holistic. And you mentioned some of the strategies, even that are very important to people's well-being and overall health. And so I'll give my perspective, but I'd love to hear from you as well if you have thoughts or experiences that you wanted to share in this setting. I think from a psychosocial standpoint. And I would like to thank our social work group here at HSS for this, because I think having a community can be really, really important to patients in terms of their well-being. And there is absolutely an interplay between how we're doing psychologically and socially and how we are, feeling physically. And so I think community can be a really important source of support. Um, then stepping back, I did want to circle back to this concept of rheumatoid arthritis as a systemic disease. So thinking beyond the joints, I think as a physician, I also want to talk to my patients about the importance of various aspects of healthcare that directly either impact rheumatoid arthritis disease activity, or rheumatoid arthritis disease activity impacts that aspect of healthcare. So gum disease and dental health is really, really important. That's been shown to be a trigger for rheumatoid arthritis, and can worsen rheumatoid arthritis. And so having good dental care is very important. If somebody smokes, so smoking is a risk factor for developing rheumatoid arthritis, can be a risk factor for developing, disease in the lungs outside of the joints, for example. So stopping smoking is hugely important as well. Vaccinations, I always talk to my patients about that when we're having conversations about different treatment options. So, I think having illnesses can cause rheumatoid arthritis to flare. Being on certain immunosuppressive medications can increase the risk of getting sick. And so you want to be vaccinated for the things that you can be vaccinated for. If somebody has lung disease related to rheumatoid arthritis, you also do, you want to be vaccinated against influenza. Bone health, we were talking a little bit earlier in the session about thinking beyond rheumatoid arthritis. If somebody, and we were talking about prednisone. So rheumatoid arthritis is an independent risk factor for osteoporosis and osteopenia. And then if somebody has had steroid treatments, that can also increase the risk of bone disease. And so I'm always thinking about someone's bone health. And then cardiovascular health. There are higher rates of coronary artery disease in individuals with rheumatoid arthritis. So it's extra important to make sure that someone's cholesterol is well controlled. You're optimizing for a healthy diet and exercise. And then going back to some of the questions that you asked about what are adjunctive treatment strategies that can help make people feel better. So for sure, optimizing sleep is hugely important. I have patients who have had really positive experience with mindfulness meditation as well as acupuncture. And so these are things that I'm very supportive of, and I like to hear from my patients what they're trying and what they're finding to be helpful. But, Eileen, I'd love to hear also your thoughts on this.
Yeah, so I was involved in the 2022 American College of Rheumatology Integrative Treatment Guidelines as one of the patient partners on that. And it was eye-opening to me about all the different integrative treatments and which ones, were had evidence behind them, and also how those reflected the ones that worked for me. Particularly, I found exercise, seeing a physical therapist probably be the next most important person in my care team to my rheumatologist. Exercise not only helps prevent comorbidities that come with rheumatoid arthritis, they also they also help just me feel better, reduce my pain, function easier, have better sleep, and less cognitive dysfunction. I've less fatigue. Of course, it takes a while for me if I'm off exercise and I have to jump back in. It takes me about 2 weeks to kind of really see the benefits of it reducing my fatigue, but it has made such a massive impact. And I'm talking the exercises that I love, because I'm only going to do the exercises that I like to do, of course. So strength training with nothing over 15 pounds when it comes to dumbbells. I don't want to put too much pressure on my joints. Resistance bands or body weight. So strength training is very important to me, as well as, swimming, the elliptical, because it's a lower impact on my joints, or going for walks. I'm not jogging, I'm not running. Yoga as well. But of course, it does take finding the right resources and advice on how to exercise with rheumatoid arthritis, because you don't want to be following fitness influencers that are telling you to do things that are meant for people without rheumatoid arthritis. And of course, focusing on my mental health is really important. Um, I saw a social worker in probably about the first year and a half after being diagnosed, and it really helped me understand, I was living with an invisible illness, and how that I should approach people's misconceptions about me. It also helped me really process grief. I was definitely going through the grief process when newly diagnosed, and prolonged grief, because rheumatoid arthritis is a chronic illness. Grief is going to come in waves throughout my entire diagnosis. So a social worker just and counseling, mindfulness really helped me process the emotions. Um, Also, occupational therapy. I think they are absolutely fantastic in my care team as an integrative approach, just because they kind of helped me learn how to pace myself, make cooking easier, just little tidbits in life that you really need, life hacks that you really need when you have a chronic disease like RA. I found myself not very big on supplements, mostly because I want scientific evidence to be there. They're extremely costly, and sometimes they're not regulated. So I'm really wary on what kinds of supplements I use, and because I also think diet can help me a lot. You can get a lot of the nutrients you need if you're following a healthy diet. I actually really don't like the word diet. I like to say nutrition. And when I was involved in the ACR guidelines, the one diet, and again, nutrition, food map is what I would prefer to call, was the Mediterranean diet. And I find that that one is the easiest to stick to because it has so many wide ranges of foods that I do love that are easy to access. And it really is just, fill your plate with beautiful vegetables. So that's how I see what complementary or integrative approaches that I particularly really like, and also have noticed the science backs it up. But I will say I also do love, um, oh my gosh, I've totally just lost the word of it. Uh, Dry needling. Sorry, it's late at night, evening for us, but dry needling, it's like deeper acupuncture. My physiotherapist, who has had advanced training in rheumatic diseases, does dry needling on my back. I think that probably helps me a little bit more with the fibromyalgia side to this, but when you brought up acupuncture, it was like, oh, I like dry needling. So yeah. Um, do you have any comments on those ones?
No, I mean, I think that thank you. And again, I'm learning from you as well. And I mean, what an amazing experience that must have been to have, your input on the guidelines. And so I think that all of that resonates. I do agree with the comment you made about supplements. I want, my patients to share their experiences with me, but I do tend to say some words of caution because the industry is not regulated. And so you may, the pill bottle may advertise one thing and it may not actually be what's in the medications. But yes, I think that all of those, I mean, exercise, physical therapy, occupational therapy, so, so, so important.
Hmm. Hmm. And I'm glad that you agree. I do hear from some patients who are unaware of these aspects to their care. So as a rheumatologist, I'm happy that you also can agree on those. And thank you so much for talking with me about these important topics about demystifying medications with rheumatoid arthritis. We're going to start closing up the discussion and start the question period. But do you have any key takeaways you would like those living with rheumatoid arthritis watching this to know?
The main takeaway that I'd want to emphasize is that this is because as you said, this is a chronic condition. This is a long-term relationship between you and your rheumatologist, and that trust is so critical. And so open communication about what's working, what's not working really is the cornerstone of, I think, a successful physician-patient relationship and the key to effectively managing rheumatoid arthritis.
I agree. I would say that would be exactly my same takeaway is keep in communication with your rheumatologist, and sometimes speaking with other patients or hearing from other patients can really help you develop the questions that you need to ask your rheumatologist. So I'm really appreciating this conversation today, having a two-way between a rheumatologist and a patient. And I hope those listening learned a little something and some takeaways that they can take away with their next appointment.